Okay, thank you very much. It is my great honor to introduce my lecture about role of OCT in bifurcation stenting. So this is my disclosure. In general, how should we implant stent in bifurcation? We should select single stenting with kissing balloon technique as possible, otherwise two stenting with curod or DK crash. For optimal stenting, full stent expansion, good apposition, and less gel strut at side branch orifice should be obtained. In bifurcation, there is a vessel size change in main vessel at proximal and distal of side branch. If the stent size selected to adjust the proximal side, stent to distal edge dissection and carina shift may happen. If the stent selected to adjust the distal side, no edge dissection and no carina shift may happen. However, stent malapposition occurs. Proximal optimization technique, POT, should be performed. So in OCT-guided PCI, there is a slogan, MLD max. So for pre-PCI, OCT shows MLD. M means tissue morphology, L means lesion length, and D means lesion diameter. As you know, OCT characterizes tissue components, fibrous plaque identified as homogeneous high intensity, calcified plaque is clear border, heterogeneous and low light attenuation, and unclear border, and lipid plaque is unclear border, low intensity, high light attenuation. This is an example of calcified bifurcation. This is diagonal branch in LAD. At the opposite side of a carina, there is a calcium in here. And if there is a calcified plaque in the opposite side of carina shift may happen after stenting. Load ablation recommended before stenting. So we decided to do the load ablation using a 2.0 millimeter bar, and OCT shows an ablation effect in here. After stenting, stent good expansion and no carina shift happen, like this. And OCT predict side branch occlusion after stenting. If side branch angle is narrow like this and carina is protruding to the main vessel, there is a high possibility of side branch occlusion due to carina shift, and side branch protection procedure should be considered. And this is another example of LAD diagonal branch bifurcation. And OCT long axis view show that at the main vessel proximal side, there is a protruding mass, and the diagonal branch is S-shaped like this. And you can imagine anti-grade wiring to the diagonal branch looks very difficult, and the reverse wire technique is recommended to cross the diagonal branch. So we have done the reverse wire technique using a crusade and Sion black like this. So OCT guides side branch accessibility with guide wire recross. If there is a dissection or protruding plaque at side branch orifice, guide wire recrossing may be difficult. And OCT auto lumen profile display shows coronary lumen profile in all scan area. It will guide stent landing zone and help to decide stent length and diameter. It is a coronary map. For example, in left main trunk bifurcation, stent diameter should be adjusted to LAD diameter, and the pot diameter be adjusted to LMT diameter. And also stent length and pot length must be precise with OCT information. For post-PCI, OCT shows max. M means a stent edge medial dissection, and A means a stent apposition, and X means stent expansion. This is example immediately after stent implantation, Zion Sierra 2.75 38. OCT software automatically detects the bifurcation of side branch of more than 1.5 millimeter diameter. So there is a two bifurcation in here, and you can understand the apposition condition in here and also expansion condition in here. So you have to consider only the post-dilatation in this area so to get the optimal stenting. So 3D OCT gives image information such as stent cell figure, location of stent link in relation to side branch orifice, and also guide wire recrossing position. To apply 3D OCT guide PCI, we need to get clear OCT image with sufficient coronary blood removal. So the method of coronary blood removal is, one thing is use of power injector, such as zone master or assist. Injection rate setting is right coronary artery is 2.5 to 4.0 cc, and left coronary is 3.5 up to 4.5. And the volume limit is volume for 4-second injection, and pressure limit is 300 psi. Other method is manual syringe with powerful hand injection. So this is one example. If you want to get the OCT image with contrast dye injection, one-time scanning requires 5 to 10 cc. Need a strong power like this using hand. The other thing is low molecular dextran injection just beside the Y connector. Push strongly like this. One-time scanning requires 10 to 20 cc injection. And this is an example of 3D OCT image with low molecular dextran injection. The important thing is check the guiding caster position where sufficiently engaged in coronary and not wedge it with checking the guiding caster pressure waveform. As test flushing to check the blood removal with OCT live image, and then you can get the OCT with low molecular dextran injection with a stored image. You don't have to do the angiogram to save the radiation dose. And you can get the OCT image like this, and beautiful 3D image you can get. So, for example, if we implant stent just size for LID, remarkable malabsorption happen at LMT. And it is difficult to recross the guide wire distally because of straight form of a stent. And if the guide wire recross proximally, after KVT, JL strut remains as distal carina. If we do pot with bigger balloon, stent malabsorption disappear at LMT, and easy to recross the guide wire cross to carina due to the gap of the stent. And if the guide wire recross distally, after KVT, JL strut move to the side branch site and get optimal result. And we understand stent link disturbs side branch opening. And if the stent link did not locate at side branch orifice, we call it link-free type. Optimal guide wire recross point is distal cell cross to carina. After KVT, these JL strut go to the opposite side and get optimal result. And if the stent link locates cross to carina, we call it link connecting to carina type. It is difficult to remove JL strut by KVT. This is a side branch orifice, and the link is here at the center of side branch orifice. And guide wire recross in this cell after KVT, this strut is crushed like this, and also pulling effect by balloon. This stent go to the proximal side, and normal stent at carina side. We call it suboptimal condition. This is another example of link connecting to carina type. Link is here, and guide wire recross in the distal cell like this. After KVT, this strut is crushed, and also by pulling effect by balloon, stent deformation happen and no longer stent there at the carina side. Actually, this patient died 1 month later, suddenly. And if the guide wire recross proximal cell, metallic carina remains at this site. In this situation, link connecting to carina type is difficult to remove the JL strut. So we propose a novel push-forward method for removing the side branch JL stent. The concept is after stenting to the main vessel, do pot, and then to the JL strut to the side branch side, and while balloon inflated, push strongly to the side branch site like this, and then do the KVT, and this strut bend it like this. This is a bench test like this, while balloon inflated and pushed strongly, and to fold the protruded stent to the side branch side like this. After KBT, you can see the good condition of the stent. And this is another example of link connected to carinian type. The guide wire intentionally recrossed the proximal cell, and while balloon inflated and pushed strongly to push this stent, after KBT, this protruded stent bended to the diagonal branch side and get optimal result. The procedure success was defined as the distal shift of the gel strut with approximately 1 crown length by the balloon push. And the pattern of gel strut removal is one thing is a shift or folded toward the side branch side like this, or strut shifted distally main vessel like this, or the folded toward the main vessel. This is an example of an LMT bifurcation. After stent implanted to the LMT bifurcation, 3D OCT show the link is here and the protruding stent is here. So guide wire intentionally recrossed the proximal cell, and the wire balloon inflated and anchor balloon like this, and the inflated balloon pushed strongly to the circumflex to bend the strut like this. And then we do the KBT. After this, gel strut shifted to the distally like this. So this is the before push, this is after push. You can see gel strut shifted distally to the main vessel like this. So far, we have done more than 30 cases push method. The target lesion is left main bifurcation or LAD diagonal bifurcation. And port was done before push was 58%, and balloon anchor method was done 61%. And push balloon size is 2.5 average, and pressure is almost 3 atmosphere. The procedure success rate was 76%, and the strut shifted distally in left main in 9 cases, and shifted or folded toward the side branch side in 11 cases, and folded toward the main vessel in 2 cases. As you know, stent folding toward the main vessel may result in significant narrowing in main vessel like this. So important thing is we should do the port before balloon push like this, a little bit bend to the side branch side, and then push the balloon so you can get the fold into the side branch side like this. So port is very important before push. So balloon push technique under 3D OCT guidance is feasible and useful for removing gel strut over side branch orifice if the stent link is located at carina. So I would like to show some case example. This is a LMT circumflex lung disease like this. And Archmaster stent 3.5 38 implanted to this lesion, LMT to the circumflex, and recross the guide wire to the LAD again. And we make sure that was OCT. And the 3D OCT show that there's a stent link is here, and guide wire recrossing this cell. In this condition, if you do the KBT, this stent crash and becomes a stent deformation happen. So ideal recrossing position should be here, but this space is very narrow. Well, so we decided to do the port using a 5 mm balloon, and then recross again to the LAD. And then 3D OCT show this previous recrossing guide wire is here, but this time recrossing distal cell like this. So you can see before port and after port, this space becomes wide and easy to recross the guide wire distal cell. So the port is very important. And then we do the KBT. And the final angiogram showed the beautiful result. And 3D OCT showed no gel strut at LAD orifice. And 8 months follow-up showed no restenosis. And good neointimal coverage was seen in the stent and orifice of high lateral branch and LAD like this. So we can stop the depth and change it to the shaft. This is another example of LAD proximal disease. You see the right side with LAD proximal site. So we implant the stent, crossover to the LMT to the LAD, and we cross the guide wire to the LCX. And we check the recrossing point by OCT. And OCT showed the guide wire recrossing the proximal cell, and stent link is here. So ideal recrossing point should be distal cell like here. In this situation, double lumen caster is useful. One guide wire in here, and if the next guide wire crossing the different cell, it is impossible to recross the double lumen caster through the stent. So at first, we make sure the stent, double lumen caster goes through the stent and bring back the double lumen caster, and second guide wire recrossing the distal cell like this. Now this time, double lumen caster cannot go through the stent. This is a sign two guide wire recrossing a different cell. So we remove the first guide wire and we check the guide wire recrossing point of the second guide wire again. Looks like a proximal cell recrossed. However, 3D OCT shows the guide wire recrossing the distal cell. Previous guide wire recrossing this cell. So we have done the KBT, and the final OCT showed no gel strut at the circumflex orifice like this. And 4 months follow-up showed no restenosis. Like this beautiful result. This is a true bifurcation 111 in LAD diagonal in here. We have done primary kissing ballooning LAD and diagonal branch. And OCT showed the dissection in the diagonal branch site. So we decided to do the curetto stenting in this bifurcation. So Zions Alpine 2.25 12 implanted to the LAD to the diagonal branch, and recross the guide wire to the LAD. This is LAD orifice, but guide wire recrossing the proximal cell. Ideal recrossing should be here. So we do the pot to widen the gap of the stent, and then recross again to the LAD. And now this time the guide wire recrossing the distal cell. So we do the KBT again. And 3D OCT showed no gel strut at LAD orifice in here. So we implant the stent Zions Alpine 2.75 38 to LAD main trunk. And then we do the pot to the LAD proximal main vessel 3.5. And we cross the guide over to the diagonal branch site. Now we cross in the distal cell. We do the KBT again. And final angiogram showed the beautiful result like this. And there is no gel strut at the bifurcation orifice. And the 7 months follow-up showed no restenosis. Beautiful result. So I think 3D OCT is useful to guide optimal stenting for bifurcation. And finally, I will show one case with a calcified bifurcation. This is calcified bifurcation in here. LAD and diagonal branch is very big. You see the calcium in here. And OCT scanning was done in LAD main vessel, but cannot pass through the diagonal branch. And we can make sure this is a calcified bifurcation. So we have decided to do the rotor relation 1.75 to the LED main vessel and rotor relation to 1.5 to the diagonal branch. And OCT show this is a main vessel rotor relation 1.75. This is 1.5 in the diagonal branch orifice. So we can see safely rotor bar size out to 1.75 because this is all circular calcium in here. So 1.75 rotor relation to the diagonal branch orifice again. And then after rotor relation 1.75, you can see the wide open of the diagonal branch site. We implant a stent, single stenting with KVT and finished like this. In this case, 1.5 years follow-up show no restenosis like this. For calcified bifurcation, lesion modification by rotor may be effective to simplify the stenting strategy. OCT is helpful to decide the rotor bar size. So I think OCT will guide bifurcation lesion PCI with MLD max and 3D. So thank you for your attention.